Hello, good afternoon. Thank you very much for joining our workshop where we will be talking about the benefits of implementing integrated CBT-E for people with anorexia nervosa. So if we start with introductions. So Lorna, do you want to start?
So my name is Lorna Collins and I am a lecturer at University College London. But I'm here to tell my story of illness and wellness and how the ICBTE model enabled me to recover from a very long and dangerous eating disorder which lasted for many years.
Thank you. And I'm Dr. Agnes Ayton. I'm a consultant psychiatrist working in Oxford, and I have been working with our team to implement this interesting model. So if I start sharing my screen.
Yeah, so today we will be taking you through the model and explaining it, and I'll give my bit of example here and there.
Thank you. Can you see my screen?
Yes, we just need it to be press it on. That's it. Well done.
All right. Okay. The other person who's helped with this presentation is Sharon Ryan, who is our modern matron and quality lead at the Provider Collaborative in the whole Provider Collaborative, but she cannot be with us today. So after introducing ourselves, I would like to start with acknowledging our team members who helped us to work in this project, and that includes a large number of professionals, including colleagues like Dr. Ibrahim, project managers like Melissa Akers, managers like Duncan Ford, and the multidisciplinary team in Cotswold House, Oxford. So perhaps if I start as a little bit of a background, the challenges of hospital treatment. I have been working in inpatient setting for about 25 years now, because I have always been interested in helping people who are severely ill. But what we don't know about inpatient treatment of anorexia or eating disorders in general, that they have poor outcomes. They often start with failure. So people feel that they failed in some ways, either in outpatient treatment or even the therapist might feel that they failed the patient. They often present in an emergency, which results in urgent unplanned admissions. Quite often the purpose of the admission is not clear for the patients or even the clinician, which of course will increase anxiety and uncertainty in the patient. And often the patients feel that treatment is done to them rather than with them. And this can result in disengagement or self-discharge or compulsory treatment, and maybe contributing to poor long-term outcomes. So over to you, Lorna.
Thank you. So in this slide, you see three images, and I don't know how good your eyesight is, but if you look carefully, you see some quite disturbing things, and they represent my complex patient experience. So I had a severe traumatic brain injury when I was 18, and what followed consequented into 20 years of compulsory admissions. And I was given labels such as treatment-resistant schizophrenia, as you see here, anorexia nervosa, borderline personality disorders, lots of things like that. And no one knew really how to define or help my symptoms. I was locked up and told that I should be locked up for life. I was sectioned and detained, compulsory admissions, and eating and food became a coping mechanism for me to deal with all of this trauma that I was experiencing in treatment. And my eating disorder was perhaps my most prominent symptom, but in a way, all I learned in these admissions was how to have an eating disorder. I was told by doctors and nurses that if I really wanted to lose weight, that I should go to the acute ward, not the eating disorder unit, because at the eating disorder unit, I would have no control whatsoever. So often when I was admitted, it wouldn't be to the eating disorder unit because I was told I wasn't thin enough. I didn't have the correct BMI level. So I was put in an acute ward to keep me safe, as it were. Ironically, it was the least safe place of all. It was very hard to get treatment. And when I did finally get that treatment on death's door, there was no opportunity for me to find recovery or be well. There was no care model as such at the eating disorder units I was incarcerated within. It was more put on a paltry amount of weight and then you'll be chucked out. So I'd be discharged while still underweight and nowhere near recovery. I recall the patients, myself included, pacing up and down the ward on an eating disorder unit. We'd pace up and down all day and all night, and we were sucked into our disorder. So you can see I'm painting a not a very nice picture here. And on the picture, bottom left, you can see highlighted and circled criminal. I felt like a criminal. One day in an eating disorder ward, the police came because one of the patients had escaped and they took her back. And I went up to a police officer and I said, "You need to take me to the prison because I'm a criminal." And I think the police officer laughed. I didn't understand why he wasn't taking me to prison. And then I realized when I went back to my room, I was already in prison. This was the worst, the utter worst. Okay, on that note, which is quite grim, I'm going back to Agnes.
Yeah, it's very difficult to hear these experiences from patients, and I would imagine that most of the audience who works on inpatient units have heard similar stories. We became interested in the multi-step enhanced CBT model developed in Italy in 2015 when we looked at our outcomes in Oxford compared with the national cohort in the UK run by Janet Treasure's team and the CBT-E in Italy just published by Riccardo Grave's team. And what we were very interested in, that although the BMIs on admissions were pretty much similar in all three groups of patients in different settings, the discharge BMIs in the UK, both in Oxford and in UK cohort, were still within the malnourished range, whilst the CBT treatment program achieved a normalization of BMI in a large majority of the patients. At the same time, when the length of stay was shortened, and similarly, patient-rated outcome measures using DDAQ reported a much better outcome. So we were very interested in how this program could be adapted to the NHS. And the multi-step CBT model was developed between Riccardo Dalla Grava and Christopher Fairburn, who have been working together now for a long time. And the two of them have produced important manuals. You will be familiar with the CBT manual by Christopher Fairburn, but I can also strongly recommend Riccardo's books. The multi-step cognitive behavioral therapy for eating disorders was very much the blueprint that we were trying to use. And more recently, he also published a book which is very helpful when we are thinking about helping people with complex cases. Quite often I hear when I talk about the treatment that CBT is too rigid, it's not very flexible, and it cannot really be applied for complex patients. And we were curious to see whether that was going to be true or not. If you look into the model, it's very difficult to argue with it. It's very much focusing on recovery, helping the patient to recover, and breaking it down to specific tasks to help the patient restore to a healthy weight, normalize eating behaviors, but also identify and correct mechanisms to maintain the psychopathology, and to help the patient to ensure that changes are lasting. There is a strong emphasis on least restrictive principles, and we will come back to that later in the talk. And the patients are treated as adults, and the staff and patients are working towards a common goal, using a whole system integrated step care model using CBT-E. So it is an overarching system. It's not just one-to-one therapy. So all members of the MDT are CBT trained, which ensures consistent communication across the whole team, and helping to develop a shared understanding of the individual psychopathology and formulation of the patient, which can result in personalized care, building on the patient's goals and strengths and particular challenges through the whole care pathway. And if we break it down to the steps that are important for the implementation of integrated CBTE, the first step is very much helping the patient to start well and prepare for the admission. The second step is the inpatient admission, which is time limited. So for full weight restoration, on average 13 weeks, admission should be sufficient, but obviously there needs to be a bit of flexibility depending on the level of malnutrition and the individual circumstances of the patient. And the next step is 7 weeks day hospital treatment to have the patient stabilize and prepare for independence. And the fourth stage is outpatient for ongoing CBT to have the patient staying well and rebuild their lives.
Can I just ask you a question, Agnes?
Yeah.
This integrated CBTE steps, how do you coordinate that? So before admission, who are you working with? And after a day patient in community setting, so you must have a partnership with different systems of care, not just the hospital.
Yeah, I mean, that is a very good question, and quite often is a major barrier to implementing integrated CBTE, even though that we have national guidelines saying that coordination and integration care is important. Sadly, quite often there is a fragmentation of care, so people might be more interested in delivering outpatient treatment, or might be interested in delivering inpatient treatment. And this is an important slide because we need to think about the patient journey rather than the professional identity. So patients who are referred for inpatient treatment are not going to stay in hospital indefinitely. We need to think about how to maximize the benefits of hospitalization, and then how to help the patient to move on safely to the community. And yes, you're absolutely right. We do need to work together with therapists and care coordinators across the care pathway. So talking about the pre-admission phase, Ricardo's initial suggestion was that most patients will require a 4 to 6 weeks preparation, which should be delivered by a skilled CBT therapist. And unfortunately, this is very rarely available in the NHS. So when we were trying to adopt the model for the NHS, we could only offer one admission planning meeting for the patients, but even that has been very helpful. And the task is very much to help the patient engage actively in their treatment, regardless of the severity, the level of BMI, the duration of illness, or the comorbidities the patient might present with. And the goal is very much to reduce and prevent any surprises in preparation for admission, and have the patient to make a commitment to weight restore and address the individual maintaining factor, and also give them an estimated time scale which should help reduce the anxiety.
So what do you do if someone comes in, they say refuse flat out to put on weight?
Well, we try to talk them around.
Okay.
And I think you.
Yeah, it's quite persuasive.
Well, I suppose that's why the formulation is really important, to help the patient recognize, well, actually, I have a problem with eating, and that problem is interfering with my life, and breaking down the maintaining factors. Malnutrition is a maintaining factor.
Yeah.
And it takes a bit of time, and that's why I'm saying that sometimes patients need more than just one session. I mean, alternatively, the community teams could also be helpful to prepare the patient. The next thing that Ricardo says, and I really like this expression, saying, well, the patient must be their own therapist. So there is a strong emphasis on encouraging the patient to take control and be active in the treatment. It doesn't mean that every patient who signs up to CBT treatment will be fully committed from the very beginning. And in fact, it's very much acknowledged that recovery is a difficult process, and it is the therapist's task to support the patient with fluctuating recovery. It can be achieved by helping the patients think about the reasons and advantages of recovery, talking about how their quality of life would be different, rather than talking about the negative consequences of the malnutrition on the physical health, because that tends to be less important for the individual, and help the patient recognize that they have a problem rather than they have a disorder as such. It is really important to have agreed goals for the admission and an agreed care pathway, and part of the integrated CBT is, as I mentioned before, to help the patient weight restore and maintain a healthy weight as an important maintaining factor, but also to work on the psychopathology and the maintaining factors, and work on ensuring that changes are lasting. And CBT actually fits quite well to inpatient treatment. I'm sure that all of you will be familiar with the CBT formulation by Christopher Fairburn. And if you look at this graph, you will know that a inpatient treatment can address a number of these aspects of the maintaining cycle. So it can help reduce, obviously, strict dieting and introduce regular eating, can help the patient reverse malnutrition, can help the patient also prevent binge eating or acting on compensatory behaviors. So actually the model quite fits with what happens on an inpatient unit anyway, but it gives a meaningful theoretical framework. And it's very much acknowledged that psychological treatment is crucial, and consistency and intensity of psychological treatment matters. So again, Ricardo uses the analogy of having different doses of a medication. So for example, if somebody doesn't benefit from an antidepressant, a certain dose, like for example 20 milligram of fluoxetine, and they might need to have an increased dose. And the analogy is applied to inpatient versus outpatient treatment. And the intensive inpatient treatment can help to address the malnutrition as a first maintaining mechanism, but then also that frees up the patient to think about addressing other maintaining mechanisms and eating problems, and at a later stage to think about additional maintaining mechanisms such as loss or trauma. It's often asked, well, what about the family? Ricardo is very clear that CBT formulation is something that can be quite helpful to share with the family if the patient is in agreement, and he recommends that for adults we should be offering at least 3 sessions and co-opt the family as a co-therapist in the treatment, and more sessions for young people if they're participating in this treatment. There is also option to refer for a family therapy if it is felt that is necessary.
Can I just say something about that, Agnes? Previous admissions, my parents were blamed for my eating disorder, which created a lot of hostility. They have naturally felt threatened and defensive, and it was very bad for our relationship. And then when I came, which I will talk to you about in a bit, when I came to Cotswold House and the eating disorder service in Oxford, it was a question of co-evolving, myself and my parents. We co-evolved together and found new ways of living with each other and of having a relationship, a new kind of relationship, communicating and being together. So it was a completely different way of healing the family dynamics.
Yes, I mean, unfortunately, there are historical models of psychological treatment of anorexia where mistakenly it was assumed that somehow the family causes illness. And modern research has shown very clearly that's not the case. And in fact, the family is probably the best and most consistent ally of the patient and for the therapist, regardless of the person's age, because your family ties remain very important throughout your life, not just during adolescence or for children. And then moving on to the next stage, the original model is a 7 days per week day patient program, which is very difficult to replicate in the NHS. Having said that, some people do require 7-day support. So having that flexibility and individual arrangement would be ideal when people are moving from one setting to another. And it's also important to use the day patient treatment for experimentation, so the patient can see how they respond to different foods, how they test out some of their assumptions that if they eat certain foods, then they will put on lots of weight, etc., etc.
So how does a day patient respond? What is the day patient response after COVID?
I'll come to that. Unfortunately, that was kind of a bomb put into the design, I'm afraid, due to the pandemic. So we kind of started working with the team on in Cotswold House to develop what we call the Oxford pilot, and there was a lot of thinking and work going into this. So we had the manual, we had the team, and we also had the online training. But of course, the NHS is very different from a private unit in Italy. We are taking patients who are detained. We have policies and procedures that the NHS needs to follow. And we also had the NHS England contract, which has been used as a blueprint for adult inpatient services, which specifies kind of three types of admission. One is called urgent unplanned admission with modest weight restoration. Then there is the symptom recovery admission, when the patients are encouraged to complete the weight restoration to normal weight, and also work on improving eating behaviors and psychological understanding, which probably is quite similar to the CBT-E, but it doesn't really address the transition and the kind of transmission that the integrated CBT offers. And then there is also the sticking plaster of planned short-term admission for medical stabilization, which is quite often used. So if you look at this slide, according to the NHS contract, probably the majority of the patients are admitted for partial weight restoration, either in an urgent, unplanned way or in a planned way, and then maybe the minority are admitted for recovery. Right, so what is the difference between treatment as usual, which is the NHS contract, and what we also used to do before the introduction of the Oxford pilot? So the treatment as usual is an eclectic approach. So there's a multidisciplinary eclectic model, and as I mentioned before, quite often the admissions are unplanned. And they are unplanned in terms of goal and also in terms of length of stay, and the discharge BMI is very much variable. And outpatient follow-up is obviously recognized as important, but quite often it includes only support and monitoring, and then maybe waiting list for therapy. Quite often it is assumed that if somebody needs hospitalization for anorexia, they are too unwell for psychological treatment. So what we try to do in the Oxford pilot, we try to replicate the Italian model with the time-limited 13 weeks inpatient admission and discharging patient above a BMI of 19.5, followed by 7 weeks day treatment and then outpatient CBT-E. And we also had the crisis management option because we felt that we had to comply with the NHS England contract, but we specified that as a 6 to 8 weeks admission, so very much a short admission, and with a discharge BMI roughly about 16, and followed up with support and monitoring, and quite often, as I said, people are waiting for therapy.
Can I just put a bomb into that argument, Agnes?
Yeah.
That surely that I know I'm talking against the NHS contract, but that basically contradicts this ICBTE system, that line, crisis management.
Yes, you are right.
What do you feel about that?
Yeah, I suppose we kind of felt that we didn't really have much of a choice in the matter, because not everyone will consent for full weight restoration, and obviously, because we are working in the NHS, we kind of felt that we needed to offer something which is time limited, but we can evaluate, because one of the things that I should have mentioned when I described the NHS England options, I don't think the outcomes of these various models have ever been evaluated.
No.
And I suppose you were asking me about the pandemic. So the pandemic put a major challenge, because although by the time the pandemic started, we were well established on the inpatient unit delivering inpatient CBT-E, the day hospitals were closed, and there was also a major problem with delivering psychological treatment. So we could only offer the time-limited admission with full weight restoration, but sadly, a lot of our patients were put on supported monitoring and waiting list for therapy rather than receiving therapy immediately after discharge. So, but we thought that this would give us an opportunity, at least as a natural experiment, to compare these different models. And I suppose in terms of implementing the model, we had a lot of help with project management. And if anyone wants to try, I can strongly recommend including a project manager who is not necessarily familiar with eating disorders, but can help staff to take on and complete tasks. And then we had a lot of questions about CBT-E, because obviously the unit previously was delivering an eclectic treatment as usual program. And a lot of staff were kind of saying, oh, well, I don't do CBT, I'm a support worker helping people in the dining room, or I'm a therapist and I can't help in the dining room because I need to have a therapeutic relationship with my patients. And by spending time together and thinking about how these different interventions fitted in with formulation, staff eventually they could see how they could help the patient address the maintaining factors. We also, in addition to the individual psychological treatment, we also introduced 20-week CBT program. And the CBT program included aspects of CBT, such as psychoeducation, formulation, graded exercise, managing emotions, skills and strategies, but also other things which should help the patient to rebuild their life and improving their pie chart. So things like using art, creative writing, photography, cooking, etc. So if you are interested in the model, it's important to get help. So get help from managers in your organization. Think about what it is that you can and cannot do. Have a conversation with staff, patients, and carers to co-produce the program so that people feel heard and listened to, and be creative, generate evidence, and share the news. And this is what we are doing here today. So I mentioned that we started the project quite a long time ago, and I can now report on short and long-term outcomes between 2017 and 2020. So the long-term outcomes, we're talking about patients discharged in December 2020, so at least a year after discharge. And for some patients, it's much longer, like you, Lorna. It was 4 years ago when you were discharged. And this is just kind of looking at the number of patients who were referred to the provider collaborative, and we included everyone who was admitted, except for people who were over 60 years old, because obviously there's a very small number and maybe different outcomes. And the numbers in the Oxford pilot, we had 34 patients in the ICBT, 38 in the crisis management, and then 48 in the CBT, standalone CBT.
What happened to the, I'm just totally interrupting you. What happened to the patients who were excluded and not admitted? They just got taken into therapy or something?
Well, patients not admitted, it is a good question. So it will be another project to look at a long-term outcome. for those patients, and there was a mixture of why patients weren't admitted. Usually, when they were waiting on the waiting list, that there was a decision either by the patient and the treatment team that the admission wasn't required. But you're absolutely right. It would be really interesting to know how the long-term outcomes compare for those patients. But we haven't got that data, so that's a separate project.
Yeah.
And the treatment, as usual, was almost 100 patients in different units all over the country. So about half of them were in independent hospitals and half of them in NHS units. And I just sort of thought it would be helpful just to show the clinical demographic details. So the mean age was just a little bit under 30, and there was a skewed distribution of age. So about half of the patients were under 25. The vast majority of them were female, and again, the vast majority had anorexia, and the rest had atypical a presentation. And we had high rates of comorbidities, particularly depression, anxiety disorder, autism spectrum disorder, and personality disorder. And about 75% were informal. When we looked at short-term outcomes, so that is between admission and discharge, we were kind of looking at all treatment as usual and Oxford, all patients admitted to Oxford. And the reason why we were interested in that, because you could argue that some of the patients in the treatment as usual groups might have been admitted specifically for a short partial weight restoration program. So we thought it would be helpful to compare them, although it didn't quite turn out to be the case. So there wasn't any difference in terms of age or admission BMI between the two groups. But the discharge BMIs were a lot better in Oxford, and the length of stay was also shorter. So that kind of showed us that we could improve outcomes and potentially reduce costs. So we were very kind of encouraged by that. If we kind of break this down to the various treatment pathways, then it does look slightly different. So what you can see that the best discharge BMIs were in the ICBT group. So people were discharged almost on BMI 20, and the CBT inpatient only group was a little bit below that. And both the treatment as usual and the crisis management group were discharged still within the malnourished range. So there was a massive difference in terms of discharge BMI in the CBT groups. In terms of length of stay, obviously the crisis management, because the 6 to 8 weeks was the shortest time. And it was quite interesting to see that actually the length of stay between ICBT and treatment as usual was not that much different, but you could still see a much better discharge BMI. So you can achieve, because sometimes, people ask me and say, well, Agnes, do you keep people in hospital for ages because you're waiting for them to get to a normal BMI? We have kind of tried to work with a patient to speed up the rate of weight restoration, and that has been working well. And then the most exciting bit is looking at the minimum 1-year outcomes. This is kind of color-coded traffic light system. So in the ICBT group, we had almost 70% of remission or good recovery rates. So people maintained the normal weight, and they weren't binging and purging according to their health records. And we had about 15% who needed readmission. And then if you compare this with the treatment as usual, the proportions are much different. So only 5% of patients in treatment is usually achieved a good outcome, and about 60% is actually more than 60% required readmission. And actually the treatment as usual and the 6 to 8 weeks admissions had very similar outcomes. So I suppose what it tells me, and we certainly kind of confirm that in regression analysis, that partial weight restoration, regardless how long it is for, results in high level of readmissions. And it's something that we shouldn't be recommending to our patients. It would be really interesting to see what patients think about this finding, because I know when I first talked to you about this, Lorna, talking about, well, weight restoration is an important thing, it was very difficult for you to get your head around.
Well, I didn't believe you, because all the consultants previously, and there had been many, had sort of said it was okay for me to be discharged at a highly dangerously low weight. So how, I just roll up to your ward and you say, no, you need to get to BMI of 20. I never heard anything like that before. So, it's a question of trust. How could I trust you? And trust takes time to build. There isn't much time, because there's not much time. You're not allowed to be in hospital for very long, thank goodness, because I didn't want to be in hospital. But it's complex, isn't it?
Well, I think that's why it's really important to systematically analyze long-term outcome data, because people can also always say, well, it's just one person, and it's quite clearly it's not just one person. It's a very clear pattern.
It really helped me when I was shown some science data, some data about outcomes in my admission. The nice swanky guy came over from Italy, from Della Grava's clinic, and he showed this similar outcomes that had been taking place in Italy. And then when I saw the science, I was able to think, actually, what Dr. Ayton is saying is true. It must be a way to recover this way.
Yes, I mean, I think for us it's been really nice to see that we could replicate the findings from Italy. So, and that shows that the model is quite robust. And I suppose because we had this unfortunate situation with the pandemic, we can also demonstrate that the inpatient CBT-E as a standalone treatment is better than treatment as usual. But a lot of patients are unable to maintain their progress after discharge and require readmission without the ongoing integrated psychological treatment. So the integration is really quite important. And when we looked at linear regression, kind of some statistical kind of magic, then what we found that the predictors of good outcome was normal discharge BMI, the integration of the CBT model, and then patients treated informally. And I suppose that kind of goes back to what Ricardo was saying. Well, it's worth spending the time to prepare patients for admission rather than wait until there is a major emergency and there is no other alternative by using the Mental Health Act. So over to you.
Okay, so just a slightly lighter slide. My experience of ICBTE is butterflies, because butterfly was my metaphor for recovery, because I was the cumbersome, uncomfortable, slow, warped caterpillar trying to find my way around life with an eating disorder. And then I turned into a cocoon. I was cocooned in the ward when I was admitted to Cotswold House, and a lot of work was done. I transformed into a beautiful being with wings. But inside the cocoon, I was admitted in 2017 because by chance I was living in the correct area to be within the catchment of the eating disorder team led by Dr. Ayton. And my admission was not just really about my weight. I wasn't about to die from malnutrition that time, but I had a very complex presentation with numerous comorbidities. And admissions. I'd recently been discharged from the acute ward at the Warnford Hospital, where the Cotswold House ward is. So literally practically opposite Cotswold House, the eating disorder ward. I'd been there a few times and stopped eating and drinking for long periods. Anyway, I had eventually had a preliminary meeting, as Agnes has just described. It was like an assessment in Cotswold House with Agnes and Sharon. Unfortunately, Sharon can't be here today. But we had this assessment and I fell over. I was walking up the stairs and Sharon gave me a glass of orange. And I thought, is this the test? Is this the test? If I drink the glass of orange, so am I ill enough if I get in? If I to get in? I couldn't really work it out. Anyway, I think I probably drank it. But Agnes was really interested in my history, my situation, how my life experiences. They're both very, very concerned about my self-harm. Naturally, was I going to do a massive overdose or cut myself on the ward, which would be very unsafe for everyone. So I was not an easy patient. And I never, throughout my admission, I wasn't a very easy patient. But the greatest thing was that I was given the chance to rethink my life and rethink what my life could be. And I was able to use my creativity during that admission. We had the formulation. Now, the formulation was a method of doing some research about my history and rethinking that. I keep saying rethinking. What I mean was like, think, what is going on? Why am I in hospital yet again? What keeps me coming back for? Why am I continually, put into hospital? Why can't I just live normally? I didn't want to be normal. Who wants to be normal? I didn't want to be normal. I wanted to be brilliant. But at that moment in time, when I was unwell in Cotswold House, I wanted to die. So I had all these sort of thoughts and feelings, etc., like entangled up in my head and in my body. But Agnes showed me a new vision of recovery, which included getting to a healthy weight. I didn't understand what she was talking about. It's nonsense, absolute bollocks. And how on earth could it be true, considering what I'd been told before. But then I saw the evidence and I realized that if I did want to get better, I wasn't sure if I wanted to get better. I wasn't even sure if I was ill. But clearly something was amiss because I was in hospital yet again. So if I wanted my life to continue being hospitalized forever until I eventually died, which might be sooner than I had thinking, or that might be a situation, or maybe I could realize my dreams of being a writer, an artist, a teacher, a brilliant person. And I, as you can see, my imagination was thinking about all of this at the same time. And suddenly I had structure, I had boundaries, I had stimulus by which I could use my creativity and rethink my life. I started to put on weight, and as I put on weight, my mind healed as well, and so I could think more clearly. And that was not always easy, that process, but I was able to use my creativity and reimagine my life. There were still things that I did want to do. I wanted to go to a dog show and do dog agility with my lovely Romanian rescue dog called Foxy. I wanted to ride in competitions. I wanted to write a book. I wanted to write several books. I wanted to be a professor, Professor Lorna. And the more I wrote my list of things I wanted to do, the more excited and happy I felt. And there was inside me a butterfly, which was Lorna, who didn't have an eating disorder. And the team at Cotswold House helped me fire that up so I could be free. And then perhaps one of the most important parts of the care system was that once I was discharged, I had help in the community. So I had a therapist in a local community hospital who I would visit once a week. And we did therapy about trauma, because I had the trauma of the traumatic brain injury and how that completely annihilated every part of my life. But I also had trauma of 20 years of being incarcerated in hospitals across England and France, which did so much damage. And during my therapy, we worked on mindfulness and compassion. And we also worked on building coping mechanisms and strategies to test out, which I would, in my spare time, test out ideas. How is this going to work? Does this help me? So painting, writing, going for walks in nature, watching the television, listening to the radio, going to talk with my family, my friends, bringing a friend at any time of the day. I had a list of things that would help me keep safe and keep well. And this was what my time in treatment helped me, until, as Agnes was saying, I became my own therapist. So now, what I do sometimes, even though I don't need therapy, but I might go for a walk and dictate a voice note to myself. And I'm just checking in. So it's grounded me and my life. And now I am a lecturer, and some of the students call me Professor Lorna. So I'm not a professor yet, but that's the 5-year plan. Okay, back to you, Agnes.
Yes, thank you very much. And it's really heartwarming to hear a personal story, and thank you very much for helping with this presentation, because I can show as many numbers as I like. A personal story is a much more powerful kind of testament that the treatment can transform lives. So just to summarize, so the conclusion, the ICBT has significantly better outcomes compared to treatment as usual or other alternatives, and this is due to probably 2 main factors. So reversal of malnutrition prior to discharge, and also the step 10 integrated psychological treatment across inpatient, day patient, and outpatient pathway. And as we could see, that without that, people are still at high risk of needing readmission. And partial weight restriction programs result in poor outcomes, regardless of the length of stay. So I think this is a really kind of important observation, and kind of thinking about, okay, how do we do that differently? So do we spend more time to persuade patients to agree to the whole care pathway, or do we need to think about more intensive treatment in the community to help people progress if they can't stay in the hospital?
Can I just say one more point, Agnes, just about in, because there's lots of bad flavour about inpatient admissions. People think it's like the last resort. For me, I was inpatient. I was an inpatient many times. For me, it was the last resort, but only because my home life at home was a prominent factor for the reason why I was unwell. And at some points in my illness, I didn't have a home. So it does make sense. It can provide an amazingly good opportunity for recovery, being an inpatient. So it does sometimes really work.
Well, I think the importance of this work is that inpatient treatment shouldn't really be seen as standalone. It should be seen as part of the care pathway, and the care pathway needs to be integrated.
Absolutely.
Yeah, and if we use a different example like diabetes, we wouldn't think that somebody can only get inpatient treatment for their diabetes and not community treatment, and vice versa. So it does need to be part of the care pathway. And I suppose we need to continue trying to think about how to strengthen this. So in Oxford, we will trial a remote step care model, where we will improve the starting well pathway, and also trialing out whether the staying well 7-day patient treatment can be replicated remotely. There are pros and cons of that, and it's a little bit of a jump into the unknown. So watch the space. And it's really important to evaluate routine outcomes in real life, because we can't put everyone in a randomized control trial in complex interventions. And if you're interested, these are the resources that I can recommend. There's also the online CBT training. And the work that we have done is completely compatible with the adult eating disorder commissioning guidance. And I would be grateful if you could go away and maybe think about how this model would benefit your service, your patients and staff, what opportunities you have, and maybe also what challenges you may have and how you could overcome them.
Yes, it'd be good to hear from you.
Yeah, but thank you very much for your attention, and we will be joining you later. Thank you. Bye-bye.
Bye then.